All right, good afternoon, everyone. I'm hoping everyone can hear me. If you want to just send a quick, yes, I can hear you in the chat box, I would really appreciate it. We are going to get started. We have an hour scheduled. Excellent, you guys can hear me, thank you. We have an hour scheduled. I anticipate we might go slightly over that with questions, but we are going to try and keep this condensed to 1 hour. I want to be respectful of everyone's time. So welcome to today's Telehealth and COVID-19 update webinar. My name is Katie Cook. I am the Telehealth Project Manager at Adirondack Health Institute. And Nancy, if you're on. Oh, hold on, I might need to unmute you. I'm sorry, give me a second. I muted everyone. Awesome, you're unmuted, Nancy.
Okay, great. Hi, I'm Nancy Del Mastro. I'm the Telehealth Project Specialist at Adirondack Health Institute.
All right, just a couple of housekeeping items for everyone. We are going to record the session and the link should be sent out by tomorrow afternoon. We are also taking questions through the chat box at the bottom of your Zoom screen. We will do our best to address as many questions as possible at the end of the webinar, and both Nancy and I will be monitoring the chat and answering questions while the other is speaking. So just a quick disclaimer, it's worth mentioning that the changes and updates to waivers and documents are occurring on a daily basis, if not an hourly basis in some instances. So the information presented here today could be updated tomorrow. So your best source of information for right now, we have a couple of options. Our website, which is linked at the bottom, you'll be able to click that link when I send out the slide deck. Or you can reference a number of other resource websites that have been created. The Northeast Telehealth Resource Center is a great place to look. The Center for Connected Health Policy is a fantastic resource and a source of much of the content that we're presenting today. So today's webinar is going to go over the following. We're going to cover our state agencies first, followed by Medicare, then the Department of Health and Human Services and Office of Inspector General updates, followed by commercial payer updates, and rounding out with some software platforms and additional resources. So I'm going to jump right into it. There's going to be a lot of information here, but again, don't fret. We will send the slide deck and a recording. So DOH released a comprehensive guidance document. It's been updated, I think, 3 times now, regarding the use of telehealth, including telephonic services during the state of emergency. So for dates of service on or after March 1st, for the duration of the declared emergency, New York State Medicaid will reimburse telephonic assessment, monitoring, and E&M services provided to members in cases where face-to-face visits may not be recommended. So this telephone communication will be covered when provided by any qualified practitioner or service provider. All telephone encounters should be documented as appropriate by the provider, and they will be considered medically necessary for payment purposes in both fee-for-service and Medicaid managed care. So payment for telephonic encounters will be supported in 6 different payment pathways utilizing the usual provider billing structure. So here are those pathways. This chart has 2 basic sections. Lanes 1 through 2 are for use by fee schedule billers, so primarily practitioners in office-based settings. And lanes 3 through 6 are for all other billers that primarily bill rates for clinic and other services. Practitioners that usually bill the fee schedule directly should bill for telephonic services using lane 1 and 2 based on practitioner types noted. So you'll see in lane 1, that's your physicians, your mid-levels, midwives, dentists, and nurses. And lane 2 would be all other practitioners billing the fee schedule, such as psychologists. For those of you that are asking about telemental health and self-attestations, hold tight, we will get there. So clinics should bill using lanes 3, 4, and 5, depending on FQHC status and practitioner type. Lane 5 is for clinics and other programs to use for the noted practitioners and should be used for any and all patient assessment and management services that are appropriate to be billed telephonically. Lane 6 is reserved for all other services that do not fit into the first 5 lanes, such as home care, CHA assessments, nurse visits. So home care is covered through this modality. More guidance is coming from DOH on Lane 6, adding to the noted services, but it's expected that over 90% of all Medicaid telephonic billing should fall into lanes 1 through 5. So these are the standard definitions from the New York State Department of Health for telehealth, but as you can see in italics, there have been some changes. So the definition of telehealth has typically always been your two-way audio visual, but for the purposes of the state of emergency, this definition is expanded to include telephone conversations. For the originating site, there are no limits on originating sites during the state of emergency. So patient's home is fine, it was fine before, but it's anywhere the member is located. And for the distant site, it's any location, including the provider's home that is within the 50 United States or United States territories. During the state of emergency, all sites are eligible to be distant sites for delivery and payment purposes, including FQHCs for all patients, including dually eligibles. And this includes clinic providers working from their homes or any other location during the state of emergency. In terms of eligible providers, during the state of emergency, all Medicaid provider types are eligible to provide telehealth, so long as that service is appropriate and within your scope of practice. So for confidentiality and consent, all providers must take steps to reasonably ensure privacy during all patient-practitioner interactions. We will discuss the OCR notification later in the webinar, but for the nationwide public health emergency, the Department of Health and Human Services Office for Civil Rights did issue a notification of enforcement discretion for telehealth remote communications. So OCR is not going to impose penalties for non-compliance with the regulatory requirements under the HIPAA rules against covered healthcare providers. We'll talk more about exactly what that means later on in the webinar. And as for consent, we've been getting a lot of questions on consent. The practitioner should, of course, confirm the member's identity and provide the member with basic information about the services that he or she will be receiving via telehealth or telephone. Written consent by the member is not required right now. Of course, telehealth telephone sessions should not be recorded without member consent. So some billing rules for telemedicine. So I'm not going to go over all of the billing rules for DOH. We have other webinars on that. That information is readily available. I did just want to throw up here, these are the standard modifiers and place of service code that Medicaid uses. So for billing your synchronous telemedicine services, you would use your 95 or GT modifier. Store and forward would be GQ. And then the 25 modifier would be if there were 2 separately identifiable E&M services by the same physician on the same day. And of course, the place of service code of 02, that was implemented by CMS back in 2017, and that indicates that telehealth telecommunication technology was used. I threw up on here teledentistry services. I don't know how many people that impacts on the line, but modifiers cannot be used by dentists. There was additional guidance on this, and I put a link to it, which you'll be able to refer to after. It does allow for 2 dental codes to be used in place of modifiers, so long as you're billing those 2 dental codes along with the originating site facility fee code of Q3014. And also just worth mentioning for individuals that are dually eligible, if Medicare covers the telehealth encounter, Medicaid will reimburse the Part B coinsurance and deductible to the extent permitted by state law. So here are the CPT codes for telephone communication. As I understand it, you would not need to bill these with a 95 or GT modifier because a 95 or GT modifier indicates synchronous 2-way telemedicine. These are for telephone E&M services based on the amount of time you discuss with the patient. So clinics, including FQHCs, billing the PPS rate can bill these codes. However, if the telephone call follows a clinic or office visit performed and reported within the past 7 calendar days for the same diagnosis, then that is considered part of the previous visit and should not be billed separately. So keep that in mind when you're thinking about how you're going to use and or bill these codes. So DOH also presented a waiver of SHINY written consent. So that's your RIOs, your Regional Health Information organizations. So HICSNY or Healthy Connections are two that I'm very familiar with. So the New York State Department of Health is allowing informed, verbal, documented consent for telehealth visits in lieu of the current SHINY written consent requirements. There are a few procedures that qualified entities and their participants do need to follow. So verbal consent shall be given by a patient to a provider prior to or during the telehealth visit, but before accessing patient information via the SHINY. Patient verbal consent shall be noted by the provider in the patient's medical record that is provided to the qualified entity. Qualified entities shall record any notation of verbal consent received as part of a telehealth visit. And this exception to written consent is temporary and shall end upon declaration by the governor that the state of emergency has been lifted. Once this happens, patient consent must once again be obtained consistent with existing SHINY regulations. So OPWDD did come out with some telehealth guidance in the wake of the pandemic. So what they have stated is as follows. So non-residential facilities and programs certified or operated by OPWDD are permitted and encouraged to deliver services via telehealth remotely to individuals with IDD whenever possible. This is via telehealth or telephone. So health and habilitation services are permitted for delivery via telehealth where a provider exercising good clinical judgment determines a telehealth encounter is appropriate. Of course, OPWDD providers should also consult any state-issued COVID-19 guidance for specific services which may address telehealth, i.e. the New York State Department of Health regs. So in the event that a service or support requires the physical presence of a staff member for the health and safety of the individual, telehealth would not be appropriate. Specifically, but not exclusively, residential habilitation, respite, and live-in caregiver services shall not be delivered via telehealth. Some additional guidelines are as follows. So again, health and habilitation services are entitled to reimbursement from Medicaid. You would follow the standard Medicaid guidelines. So in that second paragraph, the following applies to providers using telehealth. The first two were kind of the guidance as it always stood. And then the third one has italicized that providers can be licensed as a physician, registered nurse, licensed practical nurse, nurse practitioner, or physician assistant in any state in the United States and in current good standing in that state. Telehealth services need to be delivered by providers acting within their scope of practice. Reimbursement will be made in accordance with existing Medicaid policy. For the duration of the emergency response to COVID-19, providers may be reimbursed for services delivered via telehealth using technology that is not HIPAA compliant, as well as services delivered remotely through other modalities such as telephone encounters. We will talk again a little bit more later on about the HIPAA compliance rule. So for the duration of the COVID-19 emergency, this is a change from previous existing OPWDD guidance. Providers delivering services as independent practitioner services for individuals with developmental disabilities, IPSID, they can now deliver services via telehealth and bill at the IPSID rate. So that is a good change. So now Nancy's going to discuss OMH changes. Do I need to unmute you again? You should be unmuted, Nancy.
Okay.
There you are. Yep.
Great. So OMH has released expanded telemental health guidance, which supersedes all other state-issued telehealth guidance. OMH guidance only applies to OMH licensed and OMH designated programs and services. This guidance does not apply to private practitioners, and this is only applicable during the declared state of emergency. Okay, next slide. So the expanded guidance includes a rapid approval to use telemental health to deliver services, which will allow for continuity of care regardless of mandatory or self-imposed quarantines. It includes an expanded definition of telemental health and an eligible practitioner list that we will review. Programs and agencies that have previously been approved through traditional telemental health approval process do not need to submit this new self-attestation. They could continue on with their telemental health services. And programs or agencies that submitted that initial self-attestation do not need to submit a revised copy. Only one attestation needs to be submitted per agency, but please specify what programs will be covered as listed in the OMH Mental Health Provider Data Exchange or by Adult Behavioral Health HCBS service types. We have linked the self-attestation in these slides for you to click through when you get these slides. Okay, next slide. So the supplemental guidance for OMH funded programs waives the face-to-face requirements for state aid funded programs for the duration of the state of emergency. And this does this applies to the following OMH programs and designated services. And this guidance only addresses service delivery modality, which is telehealth or telephonic, but it does not change the funding amount nor the service requirements. Okay, next slide. Moving on to the expanded definitions from the OMH guidance. Telemental health for Medicaid reimbursable services is temporarily expanded. Oh, can you go back one? Or one second. Great. That was right. The definitions, thank you. So the expanded definitions for telemental health do include telephonic and or video, including technology commonly available on smartphones or other devices. And the telemental health practitioner list includes any professional, paraprofessional, or unlicensed behavioral health staff who deliver a qualified service via telemental health. During the duration of the declared disaster emergency, specific OMH license and designated programs can deliver services through telephone and or video using any staff allowable under current program regulation or state-issued guidance as medically appropriate. Any limitations and restrictions pertaining to the location of the telemental health practitioner while providing service via telemental health are waived. Okay, next slide. For applicable services, the supplemental guidance is applicable to the following OMH license programs as well as designated services on this slide. There is no change to the Medicaid reimbursement rates or methodology. In order to claim for services delivered via telemental health, providers must ensure the following. They must deliver any service appropriate for the individuals, and these can include individual, group, and collateral services, clinic integrated outpatient services, and clinic-based intensive outpatient program services. Okay, next slide. So for more information, OMH has this website, this guidance website, this first link that is very comprehensive and includes many links to various resources and guidance documents for you to review. It's updated daily with plenty of great information. We've also linked the self-attestation form and a reminder that the self-attestations must be submitted to Amy Smith at amy.smith@omh.ny.gov. Okay, next slide. We're going to move on to OASIS now. So the Telepractice Guidance supersedes any other state or federal telehealth guidance. This is very similar to the OMH guidance. It applies to OASIS certified and otherwise authorized programs and services, and all are encouraged to submit a self-attestation to practice via telehealth. And this does only apply during the declared state of emergency. And similarly to OMH, the guidance does not apply to private practitioners. Okay, next slide. So there is an expedited approval process. For this, you complete the self-attestation form, which should be submitted to the OASIS Bureau of Certification online at the certification at oasis.ny.gov. Providers may supply one self-attestation for multiple PRUs as long as each PRU is identified within the attestation. And approval occurs upon submission of the telepractice self-attestation. The approval is time limited and again effective only during the disaster emergency. And programs or agencies already designated to offer telehealth do not need to seek additional approval at this time. Okay, next slide. So for telepractice for Medicaid reimbursable service, it is expanded to include two-way audio video communication, video including technology commonly available on smartphones and other devices, and the new piece is the telephonic communication. Services to be delivered are those allowable under current program regulation or state-issued guidance as clinically appropriate and include assessment, individual, group, medication management, and collateral services. Telepractice is not limited to certified or authorized OASIS locations. The client and/or practitioner can be at any site that meets the privacy and confidentiality standards, including a home. The space utilized for a telepractice session should assure the privacy and protection of patient confidentiality. Okay, next slide, please. So the telepractice waiver and attestation was originally released March 9th, and there was updates on the 13th. The most recent updates occurred on March 18th, and they do clarify that during the duration of the declared disaster emergency, peer service delivered by SERPAs are allowable services and may be delivered by providers who have submitted a telepractice attestation or are otherwise approved to deliver telepractice services. Assessment, counseling, and other non-medical services may be provided using telepractice by unlicensed staff, case actees, and individuals who possess a limited permit. And providers should bill for services delivered via telepractice and telephonic means in the same way that they would bill for their services in person, with the addition being the inclusion of the appropriate 95 or GT modifiers, as well as the place of service code 02. And again, we have linked the billing guidance for you to review. OASIS is allowing for the provision of any services by any staff member otherwise authorized to be delivered in the certified authorized setting to now be performed via telepractice for the duration of the emergency. So again, this includes case actees, peers, as well as provisional QHPs. Next slide, please. So for technology requirements, providers should be utilizing an HIPAA and 42 CFR Part 2 compliant technology or other video conferencing solutions that the client has agreed to. We will go over the fact that HHS and the Office of Civil Rights will have released guidance that they will not be enforcing HIPAA with telehealth during this emergency, but it is still recommended that you do utilize the HIPAA and 42 CFR Part 2 compliant technologies at this time. HHS has provided a list of vendors that represent HIPAA compliant video communication products, and they do also include BAA for secure reasons. However, again, we have noted that the regulations on HIPAA have been relaxed at this time, you should still be making every effort to be utilizing compliant technologies. As for informed consent, it does continue to be required. While written consent is preferable, oral consent is permissible when it is the only available option or circumstances require immediate service delivery, which do not allow time for written consent. The verbal consent will suffice, provided the program note such in the patient records and follow up with a written consent at the earliest possible convenience. And for consent, it does only need to be documented once, while each encounter conducted via telepractice must be documented in the patient record. Group sessions can be conducted through telepractice via many of the available platforms listed on this slide. And telephonic group sessions are also permitted where a provider is able to verify the call-in was not distributed to anyone not invited. And that can be, and you can obtain consent from participants and plan for how such sessions can be conducted to ensure meaningful participation by patients. Okay, next slide. So as mentioned, guidance, I'm just gonna start over for this slide. The Drug Enforcement Agency has issued guidance waiving the requirement for an in-person face-to-face evaluation with a patient and a DEA registered data waive practitioner prior to prescribing controlled substances, including buprenorphine. A prescription can now be issued when the practitioner and patient have a telepractice session that is conducted using an audio-visual, real-time, two-way interactive communication system. Please note that telephonic-only communication is not sufficient for this. For as long as the Secretary's designation of a public health emergency remains in effect, DEA registered practitioners may issue prescriptions for controlled substances to patients for whom they have not conducted an in-person evaluation, so long as the following conditions are met. 1, the prescription is issued for a legitimate medical purpose by a practitioner acting in the usual course of his or her professional practice. The telemedicine communication is conducted using an audio-visual, real-time, two-way interactive communication system, and the practitioner is acting in accordance with applicable federal and state law. Thus, the practitioner may issue a prescription either electronically or by calling in an emergency prescription to a pharmacy. The term practitioner in this context includes physicians, dentists, veterinarians, or other people licensed, registered, and otherwise permitted by the United States or the jurisdiction in which they practice to prescribe controlled substance in the course of their professional practice. Okay, next slide, please. So here are a couple of OASIS helpful links. They have their own resource page with all of the guidance that we've spoken about. That recently updated waiver is also linked, and OASIS did come out with an FAQ sheet, which is very helpful, and many of your questions will most likely be answered within that sheet. Okay.
Excellent, thank you, Nancy. I did get a quick update that OASIS primary prevention programs should submit their attestation to prevention@oasis.ny.gov. All right, so we're going to get into Medicare. So CMS has broadened access to Medicare telehealth services so that their beneficiaries can receive a wider range of services from their doctors without having to travel. So these policy changes build on the regulatory flexibilities granted under the President's Emergency Declaration. CMS is expanding this benefit on a temporary and emergency basis under the 1135 Waiver Authority and Coronavirus Preparedness and Response Supplemental Appropriations Act. These benefits are part of the broader effort by CMS and the White House Task Force to ensure that all Americans, particularly those at high risk, are aware of easy-to-use, accessible benefits that can keep them healthy. I've received a lot of correspondence over the last week and a half of friends, loved ones, friends, loved ones who have been utilizing telehealth for the first time, and it is very exciting to see that people are latching onto this and recognizing how critical it is during this time. So under this new waiver, Medicare can pay for office, hospital, and other visits furnished via telehealth across the country, including in patients' place of residence starting March 6th. These visits are considered the same as in-person and are paid at the same rate as regular in-person visits. There is no need to apply for a waiver, nor are these waivers limited to patients with COVID-19. They cover everyone. So as you can see, the rurality restrictions have been removed, and telehealth services can now be provided regardless of where the enrollee is located geographically or what type of site they're in. They are now allowing the home to be an eligible originating site. However, billing that originating site facility fee of code Q3014, you can still only bill that for the original originating sites. So like your private practices, your hospitals, skilled nursing facilities. The home is not an eligible facility under the eyes of CMS, so you would not bill that facility fee. All services that are currently eligible under the Medicare telehealth reimbursement policies are included in this waiver. I did put a link on this page, which you'll be able to access when I send out the slide deck. The waiver did not expand the list of eligible providers to provide services. Medicare does not provide a definition of a distant site. They just limit the type of provider who can provide a service, as you can see on this bulleted list. CMS has stated that providers can simply just not be located out of the country. I did get a question the other day about a provider in Canada. Unfortunately, in the eyes of CMS, that would not qualify. So we're going to look at modality at the bottom of the screen. So the waiver did not expand what modalities can be used. So it still stands that store and forward can only be in Hawaii and Alaska telehealth demonstration programs. For out-of-pocket costs and copays, they still apply, but the OIG is providing healthcare providers flexibility to reduce or waive visits. There is a restriction on the use of a telephone for telehealth services, except that the telephone must have audio and video capabilities that are used for two-way real-time interactive communication, aka a smartphone. So as I understand it, the telephone can be used so long as it's a smartphone. I'm still a little unclear on that, but that's what I've been reading. So FQHCs, a question just came in about that. We have you covered. So the distant site rule is currently still in effect. It has not yet been waived. I've been hearing on other webinars that CMS is looking at this. So I'm very hopeful that in the next couple of days to a week, we may see that distant site restriction waived. FQHCs and RHCs can still utilize some of the technology-enabled services to treat patients, such as the virtual check-in codes or chronic care management codes, but not e-consult codes. You would receive a fee-for-service rate in that instance, not the PPS rate. Medicare Advantage plans are not required to follow this restriction, and many do pay FQHCs for telehealth services. I'm getting some notes that the current stimulus bill as written removes this FQHC restriction. That would be news to me. I looked an hour ago and that was not the case. I will update the group in my email after the fact if that distance site restriction has been waived. So Medicare and the HRSA Health Center program. So yesterday, the U.S. Department of Health and Human Services through HRSA awarded $100 million to over 1,300 health centers across the country with funding provided by the Coronavirus Preparedness and Response Supplemental Appropriations Act. So HRSA-funded health centers can use these awards to address screening and testing needs, acquire medical supplies, and boost telehealth capacity in response to the pandemic. 5.2 million of that went to 63 health centers in New York State, including several of you on the line. So within the context of the health center program scope of project, telehealth is not a service or a service delivery method requiring specific HRSA approval, but it is rather a mechanism or means for delivering a health service to health center patients using telecommunications technology or equipment. Health centers are not required to seek prior approval from HRSA for a change in scope to use telehealth, nor separately record the use of telehealth as the means to deliver a service that's already in scope on your Form 5A. So during the duration of this public health emergency, health center providers may deliver in-scope services via telehealth to individuals who have not previously presented for care at a health center site and who are not current patients. Telehealth visits are within the scope of project if the individual receives an in-scope service, the provider documents the service in a patient medical record, the provider is physically located at either a health center service site or some other location such as their home or an emergency operations center. Health centers should focus services provided by telehealth on serving patients and other individuals located inside their service area or within areas adjacent to the covered entity service area. It is recognized that in the public health emergency, patients outside these areas may seek health center screenings and triage by telehealth. Health centers that continue to maintain services for target populations in their service area and provide occasional in-scope services via telehealth to individuals outside their service area are still within their scope. So I wanted to briefly touch on Medicare telemedicine services. I hope this isn't too blurry, but the virtual check-in codes are on here as well as e-visits as well as telehealth visits. There's a couple of different buckets of codes and patient relationship with providers. So a few key takeaways here. The virtual check-in codes can only be reported when the billing practice has an established relationship with the patient. These two codes, the G2012 and G2010, are not limited to rurality restrictions, so it can be wherever the patient is. CMS has not liberalized the 7-day rule with these codes. I was on a call last week where that question was asked, and as far as the experts understand it, there still has to be that 7-day window. So if you saw a patient within 7 calendar days, and then you initiate a virtual check-in with them for the same diagnosis, say 5 days after their visit, you would not be able to bill these codes. The e-visit codes are meant to be online patient portal communication that you can bill for. So the 99 codes are meant to be billed by actual practitioners, so physicians, mid-levels, things like that. The G codes are for like your nurses, licensed mental health counselors, social workers. These services can only be reported if you have an established relationship with the patient. There's no geographic or location restrictions, and it's intended to have patients communicate with their doctors without going to the doctor's office by using an online patient portal. We've linked at the bottom a link to a lot more on this. I just wanted to put a visual in front of you so that it was a little bit easier to understand. So a few other Medicare policies. So licensing has come up quite a bit. So obviously through this public health emergency that we're dealing with, there have been numerous waivers issued. You'll want to check out the Federation of State Medical Boards website for your specific state. And New York State has stated that to the extent necessary, physicians licensed and in current good standing in any state in the U.S. can practice medicine in New York State without civil or criminal penalty related to lack of licensure. They have also stated that to the extent necessary, physicians licensed and in current good standing in New York State but not registered in New York State can practice here without civil or criminal penalty related to lack of registration. So Medicare billing under the 1135 waiver. So some of you may have seen information floating around about a DR code and a CR modifier. So the disaster-related condition code is for institutional billing, and the catastrophe-related modifier is for Part B billing, both institutional and non-institutional. Telehealth claims do not require this code or modifier. CMS is not requiring additional or different modifiers associated with telehealth services furnished under the 1135 waiver. You would always use your place of service code of 02 when billing telehealth. The only exceptions are listed here. Store and forward in Alaska or Hawaii would use the GQ modifier. If a telehealth service is billed under CAH method 2, the GT modifier is required. And finally, if you're providing acute telehealth services, acute stroke telehealth services, you would use the GO modifier. So an update from the Department of Health and Human Services. So Secretary Azar has exercised the authority to waive sanctions and penalties against a covered hospital or entity that does not comply with the basic provisions of the HIPAA privacy rule. So what does that mean to all of you? It means that there are no penalties or violations against healthcare providers that serve patients in good faith through everyday communication technologies such as FaceTime or consumer-facing Skype during the pandemic. This waiver became effective on March 15th. And, FaceTime is one of them. Google Hangouts was mentioned, and Facebook Messenger video chat. Providers are encouraged to notify patients that these third-party applications potentially introduce privacy risks. My recommendation is that you always look at a HIPAA-compliant technology platform before you resort to this, and we'll explain why a little bit further on in the presentation. An additional waiver note from HHS. So to the extent that the 1135 waiver requires that the patient have a prior established relationship with a practitioner, HHS will not conduct audits to ensure that such a prior relationship existed for claims submitted during this public health emergency. All right, so now Nancy's going to talk about a few other updates, and I'm going to unmute you now.
Great, perfect. Okay, next slide. So the Office of Inspector General issued a policy statement to notify physicians and other practitioners that they will not be subject to administrative sanctions for reducing or waiving any cost-sharing obligations federal healthcare program beneficiaries may owe for telehealth services furnished consistent with the then applicable coverage and payment rules. OIG will not subject physicians and other practitioners to OIG administrative sanctions for arrangements that satisfy the following. A physician or other practitioner reduces or waives cost-sharing obligations that a beneficiary may owe for a telehealth service, and the telehealth services are furnished during the time period subject to the COVID-19 declaration. This policy statement is subject to the following considerations. One is that nothing in the policy statement requires physicians or other practitioners to reduce or waive any cost-sharing obligations federal healthcare program beneficiaries may owe. And for any free telehealth services furnished during the time period subject to COVID-19 declaration, OIG will not view the provision of free telehealth services alone to be an inducement or as likely to influence future referrals. For example, OIG will not view the furnishing of subsequent services occurring as a result of a free telehealth service without more as evidence of an inducement. It is unclear whether the policy statement would apply to services billed to federal programs by FQHCs as facilities, since it just refers to physicians or practitioners. And we have linked that for your review as well. Next slide, please. Next, we are going to move on to some third-party payers and what the commercial space is doing in light of the pandemic. We are sticking to our North Country region and the payer mix that we often see with our partners. And we have found all of this information through their websites, but we do recommend that you reach out directly to learn more about their billing guidance at this time. So with MVP states that the member will not be responsible for any co-payments or other cost share or fees associated with an ER visit or visit and intake or a visit for in-network healthcare providers for the purpose of getting tested for COVID, any drive-through specimen collection sites, and finally, telemedicine visits, which includes MVP's new My ER Now, which is a virtual emergency room, as well as My Visit Now, which is their direct-to-consumer telemedicine platform. Next slide. CDPHP is sort of similar in the fact that they also have a virtual ER function now, which is called ER Anywhere, which is a free emergency telemedicine app for consultation, triage, testing, and treatment, which is a great, safe, and convenient alternative to heading to an emergency room at this time. They also have their Doctor on Demand platform, and following suit with all of the changes that include telephonic consultations, CDPHP does mention that CDPHP will be covering telephonic consults, audio and video with participating providers for physical and mental health services. Next slide. So a statement was made from Blue Cross Blue Shield Association president stating that all 36 independently operated Blue Cross Blue Shield companies and their federal employee program will be expanding coverage for telehealth services in the next 90 days. And the expanded coverage includes waiving cost sharing for telehealth services for fully insured members and applies to in-network telehealth providers who are providing appropriate medical services. They're also advocating for physicians and health systems to adopt telehealth services at this time. And then Blue Shield of Northeastern New York does echo this. Their website does state that they are strongly recommending their members to use telehealth to connect to doctors whenever possible. And again, they have their Doctor on Demand site for their members to utilize, and also asking people to reach out to their physicians to see if they could connect to their doctors for consults as well. Next slide. Excellus Blue Cross Blue Shield has a good amount of guidance on their website. They are stating that during the state of emergency declared by the governor, electronic information and communication technologies for telehealth will essentially follow what DOH is saying, and they will be waiving cost share for all telehealth visits, not just those related to COVID-19, for all members until the state of emergency has been lifted. So in-network telehealth visits will be covered with no member cost share when the services would have been covered under the member's policy if delivered in person, including behavioral health treatments as well. To be covered as an office visit, the telehealth consultation must include all elements necessary for the service to be considered an office visit. They do state that that the patient must provide consent prior to rendering a telehealth service, and the Excellus website does include an example of a telehealth patient consent form, which we linked on this slide in case you want to review an example of what a consent form may look like for a telehealth service. Next slide. Excellus does also list some billing guidance on their website. It does mirror DOH, and the place of service code 02 will be required. And of course, the appropriate modifiers, which we have already mentioned, must be used as well. On their website, they do mention physical therapy. They state that teletherapy must meet the criteria set forth in the corporate medical policy, and you can bill a non-MD phone only or non-MD video visit if you have a secure HIPAA compliant portal. And again, check out their website for more detailed information on what their policies are. Okay, next slide. As for Fidelis, they came out with a statement that they are in the process of updating systems to ensure members can use telehealth services from participating providers with cost sharing waived. Fidelis states that providers are responsible to ensure any copays, coinsurance, or deductible charges are waived for Fidelis Care members at the time of telehealth services, and claims will be adjusted to reflect provider payment with a $0 member liability upon processing. And again, check out their website for more on that and reach out to your representatives if you have any specific questions on any of these commercial payers. And that does end our commercial payer sections. If you want to move on, thank you.
Okay, lots of questions coming in. I am doing my best to answer all of you, but I am making a copy of all your questions so we can follow up after. A question came in about if third-party private payers are allowing preventive visits via telehealth. I don't want to say yes or no. With third-party payers, your best bet is to reach out to them directly. The information that we've pulled is what's on their website, so certain nuances and specific situations we're not entirely confident on saying yes or no on. So telehealth platforms, we've been getting a lot of questions about these as well. My first recommendation is look at your EMR, your EHR. Some of them, many of them, have a video option that can be built in. So a good example is MedEnt. I know a lot of primary care practices use MedEnt, some hospitals too. They have a video visit feature, which is an easy way for a practice to have HIPAA compliant telehealth communication with patients without having to download an app or a plugin. So for the months of March and April, MedEnt is allowing providers to use the feature at no cost. Typically, they charge $2 per day per charge if it's being actively used. When a patient is scheduled for a video visit with MedEnt, they are sent a link via email or text, which includes the appointment date, time and provider, a link to the visit, and a recommendation that the patient uses Wi-Fi. Some partners have let me know that there are issues with iPhones seeming to be fussy, but your best bet is to use Google Chrome if you have Windows 10 or Mozilla if you have an older version. The support from MedEnt has been very helpful in troubleshooting, and if you utilize this EMR, you will want to reach out to them directly to get set up and find out a little bit more. A few other platforms that we have seen be HIPAA compliant as well as allow you to sign a BAA are listed on this slide. Zoom is a very popular one, and I want to differentiate between the Zoom that we're using today versus Zoom for Healthcare. Zoom for Healthcare is a little bit more expensive. I believe you get around 10 licenses for $200 a month, but it is HIPAA compliant, and it gives you enough licenses if you have a practice large enough that it makes sense. I know a lot of practices that we work with have looked at and or used Zoom. Additionally, VidIO is one that I know some partners have used. VC is a popular one. Something you want to also be aware of is your upload and download speeds for your facility. So with telehealth visits now being offered and a lot of practices transitioning to anywhere between 30 and 50% of their visits through telehealth, you will likely see a significant increase in your data usage. So you'll want to be sure that you have enough bandwidth to support it. An additional mention here is that if you have specific technical assistance requests, I would highly recommend that you reach out to our colleagues at Fort Drum Regional Health. We are partnered together on the North Country Telehealth Partnership, and while I focus on a lot of the front-facing workflow regulatory aspects, they are very good with the software, hardware implementation aspect, and I'll be sure to include a contact for Fort Drum in the follow-up email with the slide deck and recording so that you have that information. Something else I'd want to mention is somebody made a good point in the chat box. A lot of commercial insurance companies do have their own telemedicine vendor or platform. Most of them tend to use like a Teladoc, MD Live, or American Well, and this typically goes for commercial lines of business and Medicare Advantage. So that is another route that patients are probably using. You may not be aware they're using it because I'm not sure what the follow-up may be from that if your patient's using American Well versus coming to you, so keep that in mind. But to kind of wrap up here, as we're coming to the top of the hour, and I've addressed some of your questions, not all, key things you're going to want answered when you're exploring telehealth platforms are, can I exit my contract at any time? Some may lock you into a 1, 2, 3 year contract. You want to be sure that that's a platform that you're going to be able to grow with and sustain for that time period. Is there a waiting room feature so I can queue my patients up? Is the platform device agnostic, meaning can it be used on an iPad versus a Google Chromebook versus an Android versus a Samsung? Is there an out-of-office message for overnight or off hours? Does the software have the ability to schedule a visit? This is a more advanced feature, but it's nice to have. How quickly can we deploy this? I know a lot of you are probably scrambling to implement telehealth, and I am, obviously very excited in my role that telehealth is finally having its moment in the sun. I wish it was under different circumstances, but we are here to help. Nancy and I are here to help kind of guide you through this time, and our Fort Drum partners are really good on the technical end of things. So we have a whole team dedicated to this. And, while we may not be able to come on site right now, we can email, we can talk on the phone and kind of walk you through what this process should look like for you. I applaud all of you on the line right now who are on the front lines facing this head on and taking care of patients and trying to do the right thing. You guys are amazing, and telehealth is here for you as another way to see your patients and to keep them safe in their homes. So on that note, I have our contact information up here. I'm going to send you a few folks from Fort Drum's contact information as well. The easiest way to reach us right now is through email, as we are working remote, and if the need for a call arises, we'll address that separately. I have noted all of your questions on a separate document, but again, if I don't get back to you right away, please send me an email. I'm kind of just working through and triaging everything and getting back to everyone as fast as possible. So with that, we are at the top of the hour. I was able to answer a lot of your questions in the chat box, so I thank you for joining us today. I know Nancy resonates the same, even though she's muted. We are here for you, and don't hesitate to reach out. So on that note, enjoy the rest of your day, and please stay safe and well.